welcome to The Code Tray, the podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EM PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
Our next presenter, who is Jennifer Gronski, a PGY2 EM resident at WellSpan Health York Medical Center, who will be presenting on tranexamic acid timing and mortality impact after trauma.
The objectives for today's lecture are to review tranexamic acid, discuss previous literature, and analyze an exploratory study. For some background information, in trauma, there is direct injury of blood vessels and trauma-induced coagulopathy. In trauma-induced coagulopathy, those early stages, there is bleeding, but then later stages, there is an increased risk of clots due to endothelial damage, shock, and platelet dysfunction. So normally, tissue plasminogen activator converts plasminogen to plasmin, which binds to fibrin, breaking down those clots. And TXA, or tranexamic acid, is a lysine analog. So it works by binding to that lysine binding site, therefore blocking the plasmin formation and fibrin degradation. Tranexamic acid, like I said, is an antifibrinolytic with a half-life of about 2 hours for the IV option, and orals a little longer at about 11 hours. Some adverse effects include anaphylaxis, which is usually rapid within 1 hour, but can occur a little later, up to 6 hours, and there may be some delayed hypersensitivity reactions as well. Vision loss or visual changes can occur. The mechanism is unknown, but potentially due to some vasculopathy. Myoclonus or seizures, also mechanism unknown, but might be due to the effect of tranexamic acid at GABA A receptors. And then thromboembolic events such as DVT and PE can occur as well. For previous literature, the CRASH-2 trial, or the clinical randomization of an antifibrinolytic in significant hemorrhage trial, was a multi-center randomized placebo-controlled trial in adult trauma patients with or at risk of significant hemorrhage within 8 hours of injury. This occurred from May 2005 to 2010 in 274 hospitals in 40 countries. The intervention was tranexamic acid 1 gram over 10 minutes, followed by a 1 gram infusion over 8 hours. And the comparison or placebo was normal saline over 10 minutes, followed by an infusion over 8 hours. The primary outcome was in-hospital mortality within 28 days of injury, so 14.5% in the TXA group versus 16% in placebo, which was found to have a statistically significant difference. And the secondary outcomes were comparing the two groups. So vascular occlusive events was 1.7% of patients in the TXA group versus 2% in placebo. Surgical intervention occurred in 47.9% of patients in the TXA group versus 48% placebo. Blood transfusions was 50.4% versus 51.3% in placebo. And then death by any cause, with head injury being the highest at 6% in the TXA group versus 6.2% in placebo. None of these secondary outcomes were found to have a statistically significant difference, but then a subgroup analysis was performed on the CRASH-2 trial, which showed mortality was reduced when TXA was given in under 3 hours, but not when it was given over 3 hours. That brings us to the CRASH-3 trial, which was an international multi-center randomized double-blind placebo-controlled trial in adults with traumatic brain injury and a Glasgow Coma score of 12 or less who are within 3 hours of injury from July 2012 to January 2019. And this occurred in 175 hospitals in 29 countries. The intervention was similar to previous trial of tranexamic acid 1 gram over 10 minutes, followed by a 1 gram infusion over 8 hours. And then the comparison or placebo was normal saline bolus over 10 minutes, followed by an infusion over 8 hours. So this primary outcome was 28-day in-hospital head injury-related mortality within 3 hours of injury. So for the TXA group, it was 18.5% versus 19.8% of patients, which was not found to be statistically significant. And then the secondary outcomes, they were looking at time of TXA administration and head injury-related mortality. So looking at TXA given under 1 hour, between 1 and 3 hours, and then over 3 hours, which none of these were statistically significant, as well as vascular occlusive events, and that was 1.6% in both groups. So again, not statistically significant. A subgroup analysis was then performed on the CRASH-3 trial, which showed a benefit of TXA given in patients with a GCS score from 9 to 15, so patients who had a less severe head injury. Then the STAMP trial came along, which was the study of tranexamic acid during air, medical, and ground pre-hospital transport trial, which this was a phase 3 multi-center double-blind placebo-controlled randomized trial in injured patients at risk for hemorrhage who had hypotension or tachycardia. And this was defined as a systolic blood pressure less than 90 or a heart rate of over 110 beats per minute. And this was from May 2015 to October 2019 at 4 level 1 trauma centers in the United States. The intervention was TXA given over 10 minutes, and the placebo was normal saline. The primary outcome was 30-day mortality, which was 8.1% versus 9.9% in placebo group. This did not show a statistically significant difference, but it can be clinically significant with almost a 2% difference. And the secondary outcomes were pulmonary embolism at 2.9% in the TXA group versus 1.5% in placebo, and deep vein thrombosis at 2.7% versus 1.5% in placebo. Again, these secondary outcomes were not statistically significant. A post hoc comparison was performed showing that 30-day mortality was lower when TXA was given within 1 hour, which showed some conflicting data with the primary outcome, since 30-day mortality was not shown to be statistically significant. So overall, those previous trials showed some conflicting data, and that led to this trial I will be talking about today, which is tranexamic acid timing and mortality impact after trauma. So the objectives and rationale for this study: guidelines recommend giving TXA within 3 hours based on previous studies like the CRASH-2 trial. The STAMP trial was inconsistent with results, and the objective of the study is to determine the appropriate time from injury to first TXA dose. The study design: this was an exploratory study of the PATCH trauma trial. So it was an international double-blind randomized placebo-controlled trial from July 2014 to September 2021. The intervention was pre-hospital TXA given as a bolus over 10 minutes, followed by a 1-gram infusion over 8 hours once the patient arrived at the hospital, and the placebo was normal saline bolus over 10 minutes, followed by an infusion over 8 hours. Outcomes: the primary outcome was death within 28 days after injury, which was determined through follow-up and medical records. And secondary outcomes included vascular occlusive events, defined as deep vein thrombosis, pulmonary embolism, myocardial infarction, ischemic stroke, or arterial events, as well as sepsis. And these occurred up to time of death, hospital discharge, or 28 days after injury, whichever one came first. For the selection criteria, patients were included if they were age 18 years and older, if they had a suspected severe traumatic injuries, a coagulopathy of severe trauma score of 3 or greater, and that was because a score of 3 or greater is considered to be high risk of coagulopathy. If patients received their first dose of TXA within 3 hours after injury and before hospitalization, and patients were excluded if they were pregnant, they resided in an elderly facility, or they were transitioned to palliative care. Looking at the breakdown of our study population, 1,310 patients were enrolled, then 10 patients were lost to follow-up or withdrew their consent, leading to 657 patients in the TXA intention to treat analysis, which then investigators lost data on 5 patients leading 652 patients for analysis in the TXA group, and 643 patients were in the intention to treat group for placebo, and there was lost data on 8 patients, which led to 635 patients for analysis in the placebo group. Statistical analysis, all analyses were used intention to treat principles, so meaning the randomized patients were analyzed in their groups regardless if they adhere to the protocol or not. They used multivariable fractional polynomial interaction algorithms, and this was done to evaluate the effect of tranexamic acid on mortality continuously with time from injury. Log binomial models were used for linear and nonlinear interactions with a continuous predictor and treatment variable. And sensitivity analyses were conducted for potential confounding variables. Going over some baseline characteristics, the median age was 41 years old in the TXA group and 42 for placebo. About 70% of patients were men, and the median injury severity score was 29 for both groups. Looking at the mechanism of injury, blunt force trauma, there was 93% of patients in the TXA group versus 92% in placebo, so pretty similar between those two groups. Penetrating trauma was 7% versus 8% in placebo, and then only 1% of patients had a burn injury, while 0% of patients had burn injuries in placebo. So as you could see, the majority of patients had blunt force trauma. The time from injury to first dose in minutes was 77 minutes in the TXA group versus 80 minutes in placebo. Patients who received red cell transfusions, 35% in the TXA group versus 37% in placebo. And then patients who received plasma transfusions was 3% versus 5%. So a few more patients in the placebo group had transfusions. Previous antiplatelet use was 8% versus 7% in placebo, almost similar in those two groups, and then previous anticoagulant use was 3% in both groups. A coagulopathy of severe trauma score, with a score less than 3 being 1% in both groups, a score of 3 being 38 versus 41% in placebo, a score of 4 was 38 versus 37%, score of 5 was 19 versus 17%, and then a score of 6 was 5 versus 4%. So patients with a higher coagulopathy score of 5 or 6, there were more patients in the TXA group. And then looking at the initial GCS score, a score less than 9 was 35% versus 33% in placebo, a 9 to 12 was 8 versus 11%, and then a score of 13 to 15% was 57 versus 56%. So TXA had a few more patients with a score, GCS score under 9, meaning that they probably had a more severe head injury. Going into results, this graph shows the effect of time from injury to the first dose of TXA or placebo within 28 days. So overall, it's showing that risk of death increased with increasing time between injury and first dose. The solid line, the solid black line is the risk ratio line, risk ratio for death at each time point, and the dotted lines are the confidence intervals. When the solid line or the risk ratio line is below 1 and the confidence intervals are also below 1, that's showing statistically significant. So that's roughly within that 90-minute mark and below. At 90 minutes, the confidence interval crosses 1, meaning the mortality benefit becomes less certain. And then after 90 minutes and around that 120-minute mark is when the risk ratio crosses 1, meaning that TXA has no mortality benefit after 120 minutes. So kind of summarizing all of that, risk of death within 28 days was reduced when TXA was given within 90 minutes. The percent was 17% in TXA versus 52% in placebo. The risk ratio line crossed the line of equivalence around 120 minutes, and the effect beyond 90 minutes did not reduce risk of death within 28 days. Based on those results, a subgroup analysis was performed with 90 minutes being the cutoff point. So again, like I said, TXA given within 90 minutes reduced mortality. For vascular occlusive events, when TXA was given less than 90 minutes, it was 23 versus 17% in placebo, and then over 90 minutes, it was 25 versus 23%. but this showed no statistically significant difference. And then sepsis, when TXA or placebo was given under 90 minutes, it was 34% versus 28%. And over 90 minutes, it was 36 versus 35%. But sepsis did not have a statistically significant difference either. For some strengths and limitations of this study, it used a randomized controlled trial to evaluate timing. So using a large multi-center randomized controlled trial with high level of evidence. This study used multivariable fractional polynomial interaction modeling to evaluate the effect continuously over time. So it gives a better understanding of TXA and timing rather than having cutoff points. The sensitivity analyses were performed for confounding variables such as GCS score, and this study mimicked previous study protocols. Some limitations include that it was an exploratory study. So this is giving a hypothesis rather than providing evidence. So it's hypothesizing that TXA might be beneficial when it's given under 90 minutes, but not giving definitive answers. This study was also not powered. So the original randomized controlled trial that this study looked at, the sample size was designed for functional recovery at 6 months, so not for the timing of TXA. It had limited covariate adjustment. So like I said, it adjusted for GCS score, but maybe not for some other comorbidities. And there was some missing data on patients, such as some patients were missing some 28-day follow-up. So in conclusion, the administration of tranexamic acid within 90 minutes reduced 28-day mortality. The optimal time frame is less than the 3-hour window that guidelines suggest. But since this was an exploratory study, additional studies would need to be performed to confirm these conclusions. So here's my references, and I would like to thank you all for listening to my presentation and what questions do you have for me?
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.